Hi everyone, I'm Dr. Lucky Sekhon and I'm excited to be doing this Instagram Live today talking all about fibroids with one of my favorite people and colleagues, Dr. Leigh Rosen. She's a minimally invasive surgeon, and that means she does all sorts of GYN surgeries. A lot of the time she does them laparoscopically or robotically, and this is a really wonderful aspect of our field that you can have sometimes major surgery and have a really short recovery time because it's done in a minimally invasive way. So that's what that means. Her and I did residency training together, so I feel like once you've spent time in the trenches with someone, you kind of know them in a very special way. And I send a lot of my patients now, being in practice, I send a lot of patients to her, and she is such an amazing surgeon and does an amazing job of treating Asherman's and all sorts of issues. Let's see.
Yay, it worked. How are you?
Hi, is it working?
Yes.
Can you hear me?
We're not on a private FaceTime call. We are live. Are you in your
Perfect.
office right now?
I am.
So tell me about your day. How's your day going?
My day is very busy as usual. Lots of patients, lots of fibroids. So perfect discussion today.
For the conversation. Amazing. Okay, so I have a bunch of things that I think we should talk about that I think would be relevant, and then very specific questions people sent in, and let's just see how many we can get through. How much time do you have?
I have about 20 minutes, 20, 30 minutes.
Okay, so we have a lot to cover in 20, 30 minutes. All right, so let's start at a high level. What are fibroids?
Fibroids are growths of the uterus. The uterus is a big muscle, and fibroids are essentially growths of extra muscle tissue around the uterus, on the uterus or in the uterus.
Okay, and when people hear growth, they freak out that they have cancer. So how do you make people understand that it's not cancer?
Well, the first thing I tell my patients is that fibroids are extremely common. So up to 80% of people can have fibroids. So if I take somebody off the street and have them go get an ultrasound, it's very likely that you're going to have a fibroid. The chances of a fibroid being cancer is extremely, extremely low. And the real reason why we intervene at all for fibroids is really based on your symptoms, not because of that concern.
So what are the main signs or symptoms that people should be looking out for? What are the clues that tip you off? Okay, this person might have fibroids. I haven't even scanned them yet.
Yeah. So I like to think, well, certainly there are some people who find out they have fibroids because they went to get an ultrasound for another reason, or maybe because they're trying to get pregnant, and in that workup they found out about fibroids. But if you're going to have symptoms from fibroids, I think about it as three categories. So the first category of symptoms is bleeding issues. So you might notice that your periods become heavier. Maybe you're starting to have bleeding in between your periods. I have, just a change from your baseline. So there's the bleeding component. And then you have the second component, which is the bulk symptoms. So sometimes fibroids grow really big and you feel bloated, you feel pressure. The uterus is very close to other organs inside your belly. So you might have a fibroid grow in the front and then it pushes on your bladder. So a lot of my patients are like, I have to pee all the time and all night I'm getting up. They can grow backwards, make you feel constipated, sometimes pain with sex, like any type of thing related to how large the fibroids are. And then the other category is really the fertility element of things. You might not have any of those symptoms, but maybe you have fibroids that are, altering the cavity, the center of the uterus, which is where a pregnancy would try to grow and making it more difficult in that way.
Yeah, and I think it's important to point out that just because you have fibroids doesn't mean you're going to have infertility, right?
Correct. Oh, absolutely.
I see patients for egg freezing consults, and I take a deep breath in when I see a fibroid on the ultrasound, because this is probably the first time they've ever had a scan. They're a young, healthy person with no complaints. They're just coming to me to think about freezing their eggs, and I'm looking at their ovaries, and I happen to see a fibroid.
Right.
And so breaking that down and explaining that this is not a problem. So many people have them. And because of its location or size, I really don't envision this being an issue for your fertility, but it's just good to know about your body and that it's here.
Exactly.
So when do you start to worry? That was like a big question that people sent in, obviously, is at what point are you like, okay, this could stop you from getting pregnant, even if you're not actively trying, which is the best test of fertility? What's like a red flag when it comes to fertility and fibroids?
So, I mean, I think number one is probably, well, two things. Number one, I think, is the location, or maybe not equal, but the location of the fibroid. So if the fibroid is what's called submucosal, or ultimately impacting the cavity of the uterus, the center of the uterus, which is where a pregnancy would try to grow, we know there's good data out there that shows that fibroids like that can get in the way and make it more difficult, and generally should be treated, right? Sometimes I have people who, they have such horrible symptoms from their fibroids that, the thought of fertility planning isn't even really in the cards because you're having so much bleeding,
right?
Things like that. So I would say, symptoms, but also location of the fibroids. That's
Yeah. And I think size matters too. Like,
yeah.
I've had patients where there's like a thick muscle, that's the uterus, right? The inner lining is what we care about the most for an embryo implanting.
Yeah.
And that thick muscle, you can have fibroids inside the muscle wall, and then you can have fibroids on the outskirts, which we don't care about as much for fertility. But I've had a couple of cases actually that I've sent to you where it's like, initially I'm kind of like, if I don't have to have someone get their uterus operated on, then I'm going to avoid it at all costs, because I think it's just simpler and better to proceed without if you don't think it's going to be an impact on someone's fertility. But where it was big enough and it wasn't in the inner lining, but it almost felt like it was distorting the overall shape.
100%.
Or it's taking away blood flow from the inner lining. So anything that's really disruptive to the uterus doesn't have to be in the lining.
Yes.
So it's kind of a judgment call. And I feel like I harass you all the time to look at MRI images, because that's sometimes the easiest way to get like a 3D view of the uterus.
Yes.
What do you look for when you're looking in an MRI? Like, is it just like a gut feeling based on the position and the size and everything put together?
Yes. So that's such a good point, because it's true. There's a lot of data out there looking at submucosal fibroids, which are these fibroids that are growing in the cavity. But these big fibroids that are, even if they're not fully growing through the cavity, when they're really big, they can compress the cavities. And we're talking about this space, right? The space in the center of the uterus that you want to be kind of free of any pressure in any way. So when I'm looking at an MRI, I find that I'm really able to see the pathway of the cavity, and I can kind of get an understanding of whether it looks totally distorted or if it looks fine. And sometimes when it's not clear to me, I think we talk about this too, you'll do a saline ultrasound or sometimes just an office hysteroscopy to just look and see, what does the cavity look like? Because, I do surgery all day, but I don't want to do a surgery unless I feel that the benefits far outweigh any of the risks. And so we have to make sure that that's clear.
Yeah. So in terms of tests, since we're talking about MRIs, obviously for me, like what I'm doing first is like an ultrasound, just a regular pelvic ultrasound. But as you mentioned, I will sometimes do a saline because the cavity is a collapsed space. It's like a potential space.
Yeah.
And there can be little fibroids that hide in the lining. So if you push fluid to push the walls apart, you can actually see the inner contour. So I think saline sonograms and MRIs are like really the most valuable tests when it comes to diagnosing the fibroid, everything you want to know about the fibroid, its characteristics, and the impact it might have on your fertility.
I agree completely. I think, I think that ultrasounds are great at telling us, kind of what's going on. Is there, are there fibroids, are there not? And then I think we're trying to figure out specifically surgical planning. If we're talking about potentially doing surgery, saline ultrasound is fantastic at helping to really show us what the cavity looks like. And then MRIs are extremely helpful as it pertains to fibroids, because I'm able to see the whole uterus globally. I'm able to see all the fibroids, their locations, and it's especially helpful if you are in a situation where you're contemplating having surgery or thinking about surgery. I always try and do the least invasive thing for my patients, of course, as you know, but only if I know that it's going to be the best approach to achieve the goal and fix whatever we need to fix. So an MRI is really key, in my opinion, in terms of figuring out whether minimally invasive surgery, laparoscopic, robotic, these terms I think kind of come about a lot, is an option for those patients.
Yeah. I want to ask you about like surgical approach and how that would change with saline. But before we get into all that, because I recognize some people might just be interested in treatment for fibroids as a whole, and maybe their goal isn't fertility right now. It's like fertility maybe later down the line. And right now their goal is to not have really heavy periods.
Yeah.
How do you classify the different treatments and like at a high level in terms of, the categories?
Yeah. So in general, the treatment options for fibroids, I like to think of it again, 3 categories. So we've got medication, then we've got procedures done by the interventional radiology doctors. And then the third category I like to think about is surgical procedures. And the surgical procedures can be, very minimally invasive, where there's no cuts made on your body anywhere, to more invasive. So those are the kind of 3 categories. And then in terms of figuring out what is, what is best for you, it really depends on what your symptoms are, what your physical exam is, how extensive the fibroids are, and then also the fertility goals, because there are some options and some treatment options that are not, generally recommended if you are actively trying to get pregnant. But, for example, if a patient has fibroids and their main issue and their main symptom is bleeding, they're like, my periods are really heavy. I can't live like this. It's so heavy. The easiest thing to do in that scenario, if you're not actively trying to get pregnant, is a birth control, because birth control helps to decrease the amount of bleeding essentially during your period, no matter what the cause, really. So that's the kind of easiest, way to start if it's just bleeding. But, if your symptoms are really, I don't have bleeding issues, my uterus feels really big, I have to pee all the time, I feel bloated, I feel distended, I'm really uncomfortable, there's not a lot of medicine there that can help to treat those symptoms, that bulkiness. That's
there isn't medication you can use to shrink your fibroids when they're at that point, right?
Correct, or in long term, exactly. And so that's why, if your main issues are that the fibroids are really big and you're feeling the bulkiness of it, the treatments are going to be more the interventional radiology procedures. So
that's blocking off the blood supply to the uterus,
blocking off the blood flow,
like kills off the fibroids and shrinks. But don't ever do that if you want to get pregnant one day.
Correct.
Just never.
So that's right. So
you don't want to block off blood supply to your uterus if one day you want to carry a baby, even if there's studies showing that you can do it. It's more complicated and it's harder to get pregnant.
Exactly.
But yeah,
I agree. So yeah, good point. But yeah, that's one of the treatment options that is out there for those who aren't trying to get pregnant, who it can treat not only the bleeding but also the bulkiness and fullness.
Yeah.
So it's just kind of gathering all the information, like what are your symptoms, what are your goals, what do you actually have going on, what is the extent of your fibroids, and you figure that out by having a physical exam and getting imaging, like we talked about, ultrasound, MRI.
And then the next category is surgery, right?
And then there's surgical options. So there's, again, even within the surgical options, you have to kind of figure out what are the fertility thing is really important, right? Because for someone who wants to get pregnant and is thinking about surgery for fibroids, it's really going to be myomectomy. Myomectomy means removing the fibroids from the uterus. Okay.
Yeah.
And different ways in which that's done depending upon the situation.
So I think something that confuses people, and understanding how fibroids are stimulated and grow can help, is why would birth control help, right? So I think what people don't realize is that these are small benign tumors that are stimulated by estrogen. And when you take birth control, yes, you are taking in estrogen, but at a very low level. and it's shutting down your body from producing the higher levels of estrogen that would normally feed the fibroid. And it works the same way for endometriosis.
Right.
So anything that's shutting down ovulation is going to help shrink your fibroids.
Right.
But obviously that's the opposite of the goal that I have for patients who are trying to get pregnant. So if you have bleeding, but you're actively trying to get pregnant, you're not going to take birth control, and maybe the best option is surgery if the bleeding is so bad, but maybe we could just get you pregnant, and that would also act the same way as birth control, right? You're not going to get a period for the 9 months that you're pregnant. So it's a little tricky, and I think it's really confusing to patients. But I also know that it's confusing to patients that there's so many different surgical options. So let's think of an example. Someone has like a 1 centimeter fibroid, but it's like right in the inner lining, right where an embryo would want to implant, and I send them to you. What's going to be your approach?
So that's the type of situation where it could be reasonable to do what's called a hysteroscopy, right? So you're saying that this 1 centimeter fibroid is right in the location where a pregnancy would try to grow. So in those cases, it would definitely make sense to go inside the uterus with a small camera. That's called a hysteroscopy. Identify the fibroid and remove
through the
fibroid
vagina.
through the vagina.
Right.
So what it means is basically you would put everything for a hysteroscopy. That's the term, camera in the uterus. So you take a really small camera and it goes in the vagina, into the cervix, into the uterus. So there's no incisions or cuts being made anywhere on you. It's all vaginal.
Yeah.
The camera goes inside, you identify the fibroid, and the fibroid is removed in that way. And so this is the type of procedure that's done, you have the procedure, you go home the same day. It's a very minimal recovery, again, because there's no cuts being made on your body. It's just all vaginal.
It takes you like half an hour, right?
Takes me about half an hour, absolutely. And most people most people go to work the next day, feel fine. Yeah.
Now, when I send you a patient like that and I'm doing the saline sonogram, or maybe you do the saline sonogram, it matters how much is actually in the cavity versus sometimes you can have some in the cavity, some stuck in the wall, and maybe you're not going to be able to get the full thing out with a camera inside this is the uterine wall, by the way. You know, it might not be like you can get the whole thing out because it's like 50-50.
Yes.
So I feel like those are important things that we can gather information about by doing the imaging as well, right?
Absolutely. It's super important that we have good imaging to see where this little fibroid is located, because depending upon how much of it is accessible or how much of it is right in the center, determine, like on the imaging, helps me to be able to tell patients, all right, listen, I feel confident that I'm going to be able to remove this entire fibroid in one procedure. But sometimes if the fibroid is partially, outside the cavity or therefore in the wall a little bit, it might mean that the whole thing can't be removed in this way. It also might mean that you might need 2 procedures to do it. But the imaging really helps us to figure out and gauge that, so you can manage expectations and also get a global sense of the uterus. Yeah.
So what type of situations would require you to would not allow you to get to the fibroid with the hysteroscope through the vaginal canal?
Yes.
And you would actually have to make incisions on the abdomen. Like, in what situations does that occur?
So kind of like what we're talking about, when you have a fibroid, if the fibroid is bigger and the fibroid is, extending closer to the outside of the uterus, such that, it cannot be removed in this approach by going in the vagina and into the uterine cavity, that's when I would say, all right, let me look at your MRI, which I would obtain, and I would see where the fibroid is located. And that would probably mean, if it can't be done vaginally, that you would need either laparoscopic or robotic surgery. What does that mean? It means small cuts on the belly in order to do the surgery. And that's the kind of phase before the more traditional surgery, which is like one big cut down by
like the C-section incision, so that you can like look at the uterus and actually then just operate on the uterus directly. When do you decide that that's the right approach versus doing it minimally invasive laparoscopic with just a few small centimeter incisions? When do you have to do the open C-section procedure, which is more major?
Yeah, so it people ask me this all the time. Is there a size of a fibroid that's too big to be done minimally invasively? It's really not one thing. It's kind of a combination of things. So I factor in certainly my physical exam when I examine my patients, and I see, how does the uterus feel? How big is it? How much space is there to do the procedure? And then with my MRI, I'm able to look at the imaging and figure out, are there innumerable fibroids? Is the fibroid, are there so many that they're so large that I think it would actually be safer to do a traditional, like a C-section cut? Because at the end of the day, the goal is getting rid of the fibroids, repairing the uterus to its normal state, and making it optimal for fertility. So I always want to do the least invasive approach that I can, but not if it's going to serve us well in terms of our end goal.
Yeah.
But it was actually,
and I feel like sometimes, sorry, go ahead.
No, I was talking about this earlier with someone here. It's so important that when you're a patient and you are in a situation where you're being told you need a surgery for fibroids, like we're discussing, it's so important that you feel like you understand, number one, why is someone telling me I need to have surgery? And number two, why is this person telling me that I need to do this specific, do I need to have it done in this specific way? I want to understand, why is this the best approach? So I just think it's critical.
And I feel like you and I see a lot of people that maybe are coming to us for second opinions.
Yes.
And so when I think about those second opinion consults, it makes me realize how important it is to have these conversations. Because for you and I, this is like every day. We take it for granted maybe, and we're like, this is pretty logical and simple and straightforward. But we hear some crazy things. And I think it is important to, as you said, understand logically what the plan is, because it's not that complicated. You have a big muscle and they're just these round muscular tumors, and we want to cut them out or we can leave them behind. It really just depends on the situation and how it's impacting the big picture. And sometimes patients have come to me and been like, I have this 2-centimeter fibroid that's not anywhere near the inner lining, and I've been told that I need surgery.
Yeah.
And I can't speak to what that opinion was, but I disagree with that opinion. So I feel like it is important to have a low threshold to get a second opinion if what you're being told doesn't make sense, because it's a big decision to get surgery. And I also see sometimes that people will be so committed to having it done minimally invasive that they're willing to ignore other problems that could have been better served to just do it open, do it once, and get all the fibroids that could be impacting your overall symptoms, whether it's bleeding or fertility. Sometimes people are like, I'll just take the big one out and then leave these other ones behind that could also be causing problems. Do you see that all the time? I see
that all the time. And I feel that it's, surgery is a big deal, right? Most of the time, everything goes fine, but it's important. It is a big deal. And I want to make sure that people know when you're signing up for a surgery that you're getting the most out of it, right? So if I have a patient who has, this is what you were talking about with the C-section type cut versus the minimally invasive. If I have a patient who has multiple fibroids and I know that I can remove all of those fibroids with a C-section cut, but I don't feel that they can all be removed minimally invasively, I would strongly encourage that person to understand, well, you're going to undergo a surgery. You want to make sure that after the surgery, you don't have any fibroids in there. This will minimize your risk of needing a second surgery, as fibroids can grow back or continue to grow. But you're right. It's so true. I have that too. I have patients come to me saying they need surgery, and I'll say, well, I don't know why. I'm looking at your imaging. I'm trying to figure out, like,
you're like, your problem solved.
I was like, I
didn't
do anything, but am I missing something here? So it's super important. And I really think just making sure they understand why something is being recommended to you.
Someone asked me a good question. I had to think about it for a second. They said, do you think that every submucosal fibroid should be removed? And I was like, I think most of them should be removed. But I feel like if it's really low down and it's small and it's nowhere near where I would want an embryo to implant, I might be okay leaving it behind. But it's like those very rare circumstances.
It's difficult. And I often, what I'll do when I have patients, when we're talking about this, it's at the end of the day, it's about the patient, right? And how do you, and who you are. Do you, how do
Yeah.
you know, are you the type of person who's going to be like, all right, I have this fibroid. Some people told me I should remove it. Others say it's probably fine. But now I'm just going to be thinking about it. And am I going to then, as I go on this journey and trying to get pregnant, if anything happens, am I going to be, why didn't I take care of that fibroid? I mean, that's, you know, and other people are like, you know what, I'm actually okay. I've accepted this. I'm going to leave this. I'll see how things go. It's also about who you are and what's going to, you know.
Yeah. Yeah. And they can grow over time too. And you mentioned regrowth. So after you operate on someone and you're like, I've cleaned you up, the fibroids are gone, and now go on your merry way. Are there lifestyle choices? Are there things that you advise people to think about that might reduce the chance of them growing back? And when you do see patients come back to you, or if there's any long-term follow-up on your end, what is like a realistic timeline for the average patient who has significant regrowth? Like, when is it normal to see regrowth, and when should you be like, that's really fast and I need to worry about that? That's a lot of questions in one.
Yeah,
Go for it.
so, well, first of all, I want to say it's very important. You know, a lot of people come to me and they're like, what did I do that I got these fibroids? And I'm like, nothing. This is so much of it is genetics. And again, what I said in the beginning, 80% of people have them. So I really think it's so important people cut themselves some slack and take themselves off the hook, because this is, you know, it is what it is. You know, there's nothing that choices that were made that is what caused you to be in this situation. So I just want to start with that.
Right.
In terms of things that can be done, I have had a lot of patients who have made some lifestyle change modifications, or have changed things in their diet and their, you know, exercise, things like that, that they have said has helped with some of the symptoms of fibroids. As for whether those things are going to decrease the risk of fibroids coming back and the speed with which they come back, the data is a little bit, you know, not super clear. Some studies have looked into vitamin D levels and shown that, you know, making sure your vitamin D levels aren't too low is a really good way to help in this scenario. But
isn't that one of the proposed mechanisms behind why it's more common in Black women to have fibroids?
That is,
right?
it's
like
not
people
not
with melanated skin have lower vitamin D levels.
Yeah. So, you know, that, and but yeah, I mean, I talk to my patients about it. It's frustrating. Talk to my patients about the fact that fibroids can regrow, and they do regrow. And in terms of, I do think it's a little bit of a case by case basis. So when I see somebody and I'm taking care of someone who has multiple fibroids, and we do a surgery and we've removed many, I think those patients are, you know, also factoring in your age and, you know, what, you know, are a higher chance of having fibroids regrow in the future than someone who maybe, let's say, has one fibroid at the time. That's just been my experience. But, you know, anywhere from 15 to 20, 30%, you can see it coming back. But as for whether someone's going to need a second surgery, that's not as clear.
When patients come to me and they have an infertility workup, and I discover for the first time that they have fibroids, and I think from the imaging it looks like surgical intervention is warranted because it's going to interfere with an embryo implanting, I want to make it really clear that doing that, because people freak out and they're like, well, this is going to delay everything. So I want to just talk very briefly about how you and I, it's like a dance, right? Like I'll think about what the priority is. If they're doing IVF, I'm like, the time sensitive thing are the eggs, the ovaries and the eggs they contain. So if I can get to the ovaries vaginally to do an egg retrieval before a myomectomy, before the fibroids are removed, I'm going to prioritize that, right? But sometimes fibroids are in the way. They're like lower down, and I can't monitor the ovaries properly. I can't see the follicles. If I can't see the follicles, maybe that will be a suboptimal situation for stimulating your ovaries and knowing when to actually call it and do the retrieval. So if I can't access or monitor the ovaries, I'm going to send them to you first and get the fibroids taken out. And then pretty quickly after, like once they're back on their feet and recovered, depending on whether you did it minimally invasive or versus open, which is a longer recovery, then they can come retrieve their eggs. But my preference is if I can get to the ovaries and the fibroids really aren't going to get in the way, and that's my judgment call, I will take the eggs out, freeze them if they're doing egg freezing, or turn them into embryos and freeze them. Then I'll send them to you. Then you fix up the uterus and make it look nice. And then you send them back to me. And then I do the transfer. And I think a lot of people don't realize that that's the type of decision making and how we work together. But one question that I'm setting you up for is, what is the timeline and how do you determine that? Obviously, it's on a case-by-case basis, but just to give a general range for depending on the type of surgery that people have had, whether it's like a hysteroscopy with a camera through the vagina into the uterus to just shave off the fibroid, which is quick and easy, versus like a more significant procedure. How long till they can come back and do their embryo transfer or start trying to conceive?
Sure. So with a hysteroscopy, which is the vaginal procedure we talked about at the beginning, which is just, going in vaginally and removing a fibroid, so there's no incisions. I'm usually comfortable saying, waiting a month for the next cycle. But obviously if we're working, so I usually feel comfortable saying a month. As for the laparoscope, so the minimally invasive or the traditional surgery where it's like a C-section cut. So it's important to note that
cutting from the outside of the uterus instead of the inside, you're going from the outside.
Coming from the outside. So whether you're doing the surgery minimally invasive, meaning small cuts versus one big cut, that's really referring to the cuts on your skin, on your belly. What's being done to your uterus is very similar because you're removing fibroids from the outside. You're coming from the outside of the uterus, pulling the fibroids out, and then repairing the uterus, fixing the uterus once you've removed those fibroids. It's very different, but the point is for those types of surgeries, I usually say about 3 to 6 months of waiting time before you can try to get pregnant, depending, but again, that's
why are you telling them to wait?
Well, because I want to make sure that the uterus itself has had adequate time to heal before it gets pregnant, because when you get pregnant and then, it's not that the uterus itself isn't ready for pregnancy. It's that I want to make sure that your uterus has adequate time to decrease the risk of having issues when you are pregnant in terms of those areas on the uterus where the fibroids were that are still healing have time to heal.
Right. Yeah. Like you don't want a uterine rupture. You want the muscles to have integrity. So I know you have to go. So I'm just now wanting to go through some of the questions that people asked here. They're really brief. What do you think? So we were talking about size. Someone said, what by definition is a small fibroid versus something that's more sizable? I feel like 5 centimeters is like an accepted cutoff for like if it's larger than 5, it's more sizable, right?
Yes.
And then someone asked about ways that you can prevent scar tissue after removal. So whether you're doing hysteroscopy or you're doing it from the outside and doing the laparoscopy or the open procedure, are there things that you do to prevent scars in the uterus and outside?
Yes. So it kind of depends, what the case is, but there are ways to prevent scarring within the uterus as well as on the outside of the uterus. But I think what we're focusing more on is, scarring in the uterus as it pertains to fertility, right? So sometimes what we'll do is leave a little balloon. It's literally a little rubber balloon that will stay inside the uterus, in the cavity of the uterus
to keep the walls apart.
Exactly. So like, again, the cavity is not open like this. Normally the cavity is closed. But if there was surgery that was done within the cavity of the uterus in order to help prevent scarring from forming, you leave a little balloon to keep the walls apart so they don't scar together. And that balloon usually stays, it varies, but usually about 7 to 10 days. And then in addition, it would also give some estrogen therapy to help with the healing of the lining and an antibiotic as well. That's usually.
But you don't always do the balloon, right? No. That's like usually if it's like a significant surface area and you're like it's going to be sticky.
Exactly.
Or if there's like 2 opposing sides that you resected fibroids from, right?
Absolutely. It's only in certain cases where I think, I actually am concerned that given the extent of the fibroids, where these fibroids are and how we have to remove them, that we are in a situation where at risk of scarring forming. So I would take that measure and that step, but no, not always, not necessary.
Okay. I mean, this is so much information to take in, but honestly, people sent in so many very detailed questions. So I feel like this was like Fibroids 101 to lay the foundation.
We need
but
to do
maybe
more.
we can do like I think we should do a part 2 to answer the very specific questions. And I saved all of the ones that you guys sent in on the question box. So maybe we can do that like next week or the week after. But I would love, I didn't introduce you properly because I'm a bad Instagram live host. Where can people find you if they have fibroids, endometriosis, or any sort of GYN surgery needs?
You can find me. I work at Mount Sinai Hospital. You can find me online. You can call me. You can find me through RMA as well. So
yeah,
Mount Sinai
you
Hospital.
can just call up Mount Sinai and ask to see Leigh Rosen or her partners at Upper East Side Sinai GYN. Is that what you guys call yourself?
That's it.
But also you should follow her because she's going to blow up and have so much good content because you're very relatable. I love the way you explain things. And anytime I send patients to you, the number one thing they say to me, and then I get really like jealous kind of, because they're like, she's got the best bedside manner of any doctor I've ever met. And I'm like, thought I had good bedside manner. No, I'm just kidding. But you really are really great with patients. And I feel like the prospect of surgery can be very daunting and scary to people, but you make everyone feel safe. And that's all anyone can ask for.
This is great. I'm very much enjoying this. This is a great Instagram. All these comments.
I really mean, no, but I mean it. So I'm so happy you're finally online and you're going to start sharing your knowledge with the masses. But yeah,
thank you.
If anyone wants to
Thank you for guiding me. Yeah. I love you, Lucky.
I love you too. So I'll see you soon and we'll do this again. We'll do fibroids part 2. And then you guys can always send us suggestions of other topics you want to cover.
Perfect.
Have a safe commute home.
Thanks.
Love
Bye.
you.
Love you.
Bye.